So welcome everyone. Thank you for joining us today for our Cardiology Grand Round. We have the pleasure of having our very own Dr. Marcus present today. Dr. Marcus is a professor of medicine and associate chief of cardiology for research at UCSF. He completed his internal medicine residency training at Stanford University, where he also served as chief resident. He then completed his cardiology and electrophysiology fellowships here at UCSF. His research focuses on cardiovascular effects of alcohol and caffeine and other common modifiable life factors. He also focuses on genetic epidemiology, mechanisms and therapeutic options in managing atrial fibrillation, cardiac ectopy, and supraventricular tachycardias. Dr. Marcus was a co-leader of the Healthy Heart Study and is NIH-funded Eureka platform with a focus on leveraging mobile technologies to help make clinical research more efficient. He has had continual funding since he joined faculty in 2006 with multiple NIH grants, as well as funding through PCORI, the AHA, and tobacco-related disease research program, to name a few. He received the AHA Samuel A. Levine Young Clinical Investigator Award in 2010, and he has mentored many of our fellows, sponsored several fellowship grants from the NIH, AHA, and the Merck ACC. So I'll hand it off to you, Dr. Marcus. Just a reminder to everyone joining us, feel free to put any questions in the chat or the Q&A box. We'll answer them at the end.
Great, thanks so much, Joyce, for the kind introduction, and hello, everyone. Hope to make this interesting and informative, focusing on patient-centered research, and I understand that one could ask the question, wasn't all medical research ultimately patient-centered, especially clinical research? And I do want to emphasize that by this, and sorry, here are my disclosures. I really am referring quite specifically to research that interfaces directly with the patient and ideally has implications without any sort of incremental science that's required. Obviously, that sort of research is extremely important and arguably the most foundational, but this is really at the most kind of distal end as we interact with our patients. And this is kind of a framework that the NIH has provided in thinking about this. And this is admittedly a bit of a hodgepodge in my attempt to curate multiple studies, and I'm going to focus on our original research kind of into one admittedly broad theme. And I also want to emphasize, really highlight so many of the important contributions of many of our fellows as well as other trainees. And also wanted to encourage everyone to think about using some of these resources that we're trying to develop to help facilitate everyone's research, and especially those in the division. I'm going to start with a few slides about diagnosing arrhythmias directly in patients, and then most of the talk will focus quite a bit on prevention, and then we'll shift gears to some research related to procedural approaches relevant to patients. So first, in terms of diagnosis, I wanted to remind everyone of this great work that was co-first authored by Jose Sanchez, then a fellow, and Geoff Tyson, where we published the first report to demonstrate that an Apple Watch, or really any smartwatch, could detect atrial fibrillation. This was before Apple came up with this bright idea. This was working in close collaboration with a company called Cardiogram that spun out of our Healthy Heart Study, founded by Brandon Ballinger, who's there, the third author, and they really helped with a lot of the machine learning that was involved. And we demonstrated that in sedentary patients that we could reliably infer atrial fibrillation from the irregular heart rate detected by the smartwatch. But in an ambulatory validation that was done among healthy heart participants, the accuracy was not great. And so we really introduced this as a proof of concept that this could work, but we didn't think it was really ready for prime time, nor did we suggest that this should be used broadly, especially for screening of AFib, which I think is the direction that this has gone in. And of course, then Apple famously published or sponsored this study run by Mintu and Marco at Stanford. And the critical kind of punchline to this, in my view, is this, this percentage, which is 34%. So 34%. So of those that had an irregular heart rate notification that subsequently wore a ECG patch, which was a pretty small number considering the very large initial denominator, 34% were found to have AFib, and that's arguably the positive predictive value, which means there's going to be a lot of false positives. Now, to be fair, this was before really introduction of the ECG feature, which almost certainly helps with the accuracy. But I think this is kind of an interesting sort of transformative moment for that we're all experiencing related to the nature of industry, which is no longer heavily FDA regulated, big pharma, or even, you know, implantable devices, but is somewhat circumvented those are normal processes and arguably subverted them to some degree, as I wrote about in this invited commentary about these phenomena. So on the left here is the kind of conventional workflow where we start with scientific research that's then peer reviewed. Only after that peer review is it disseminated through presentations and publications. That makes its way to expert consensus statements and guidelines. That's what informs clinicians, and then the clinicians then interact with their patients armed with that knowledge. In contrast, what's happened now and what is currently happening is shown on the right, where we start with really private industries such as Apple as an example, and I don't mean to pass judgment here. This is simply what's happening without even saying this is good or bad per se. But they are marketing now directly to patients and the general public. So the interface is now between the industry that is providing the tools to make a diagnosis directly to the patients before we've had a chance to really do all the rigorous scientific research, which is shown here on the bottom. So of course, we're trying to do that, and I will provide an example of more opportunities to do that, and that's undergoing peer review, and that will be disseminated in the normal way, and hopefully make its way to expert consensus statements. But in the meantime, the public is consuming this, and they are undergoing AFib screening. So, you know, there's all this talk in the literature and in the emails we receive to professionals about, well, should we screen for AFib? We don't know, but people are being screened for AFib whether we like it or not. So I think this has a couple of interesting implications. One is, should there be expert consensus statements and guidelines now that are written for the lay public to better inform them, here's why you might wear one of these devices. Here's what you should do if you have a positive alert. And then secondly, of course, we need to really continue to support original research. And in that light, I wanted to just mention Eureka, which Joyce kindly mentioned in the introduction, and this is deserving, of course, of its own talk. I co-run this with Mark Pletcher and Jeff Olgan, and Alexis Beatty has recently joined us on the executive committee. And this is really an NIH-funded platform that's meant to facilitate mobile health-based research very broadly. It's actually disease agnostic, and we've run now more than 40 studies using this, most recently several focused on COVID. And there's a research platform that includes a mobile app or web-based studies. We now can provide access to very large numbers, hundreds of thousands of individuals that have volunteered for research. And we have a back-end data repository, which incidentally is also a very rich area for all of you to think about mining as we have much more data than we have time to write up. And as kind of an example of this, what we now consider one of our flagship studies is the COVID-19 citizen science study. I would say that alongside our healthy heart study. Again, the majority of studies actually are being run primarily from investigators outside UCSF, but these are our own studies. We also have several others. This is now up to 92,000 or more participants from all over the world. And again, there's more data here than we have time to dive into. So please let me know if you're interested in any secondary data analyses. And I just wanted to highlight, coming back to this issue of studying the effects of these wearable devices, we do, as participants come in, if they have an iPhone, and it looks like about 50% of these individuals do, they're invited to share their health kit data, which from the beginning has included step counts. But if they have an Apple Watch, we're now collecting those data. So we will be collecting and are collecting irregular heart rhythm notifications, electrocardiograms. We ask about healthcare utilization, incident, heart disease and stroke. The COVID citizen science study is not only focused on COVID and really is a pretty broad sort of cohort. So again, please let me know if this may be of interest. Okay, moving on to the bulk of the talk that will be about the prevention of arrhythmias, which has been a bit of a mission for me to, along with many other investigators, to shift the general thinking about arrhythmias into the same realm as coronary disease, to think about arrhythmias as preventable, and specifically to think about how lifestyle factors, how things that are under the control of the individual can be used or leveraged to mitigate their risk. And Prash Sanders in Adelaide, Australia, has been a big champion of this and really led the way with very high quality studies, as demonstrated by this important randomized trial where they took obese patients with atrial fibrillation and randomly assigned them to weight reduction strategies versus not. And they demonstrated that indeed, if patients could lose weight, they could reduce their AFib burden. So as usual, physical activity is good for you now entering the realm of arrhythmias. We attempted to contribute to this in an observational study, just trying to understand what actually influences the frequency of PVCs, and one of the modifiable risk factors in addition to smoking cessation was in fact more physical activity. So more physical activity, less PVCs. So I want to focus now on these two extremely commonly consumed substances, alcohol and caffeine, which I find especially fascinating because they're so commonly consumed, but also because there's such ambiguity in the health effects, or at least so we think, and so the literature would tell us for now. So starting with alcohol, this was a very nice meta-analysis that summarized most of the data on alcohol consumption as a predictor of AFib, and the summary estimate suggested that yes, indeed, those who tend to drink more alcohol chronically tend to experience a higher risk of atrial fibrillation. Now, there are multiple important limitations to the studies that all went into this, and I don't mean to disparage them. One of these is my study from when I was a fellow, and then there are several by a very close colleague and collaborator, Ken Mukamal, who's a world leader in alcohol research, and he and I are in the process of trying to put together the first, a grant to do the first real prospective randomized trial of moderate alcohol consumption versus placebo. So important limitations to these studies. They all tend to rely on self-report of alcohol consumption. They are all observational, and they all really focus on chronic effects of alcohol. So we've tried to tackle each of those. This is one example that Ziggy Whitman, now at Temple, first authored, where we tried to avoid a reliance on self-report of alcohol consumption and instead leveraged healthcare coding from every hospitalization and emergency department visit in California over 5 years, and indeed found that those coded as having any sort of alcohol use problem over time had a substantially higher probability of developing atrial fibrillation. Interestingly, a higher probability of myocardial infarction, despite the common wisdom that alcohol may protect against MI, and the data really demonstrating that is much more in the drinking in moderation, and then a higher risk for heart failure. Now, as I mentioned, these are all limited by the fact that they're observational studies. And the reason that that's important is in really any observational study, meaning we're not intervening, we're not doing an experiment, we're just noticing what's happening as people go about their actual lives. The concern is always that we have this predictor of interest, we can find associations with the outcome, but it can always be confounded. And especially these lifestyle factors, whether it's physical activity, alcohol, or caffeine, they all tend to travel with other factors that may actually be causal, whether that's just being more aware of one's health, being higher educated, higher socioeconomic status, having better access to healthcare, all those sorts of things. So the question is, can we better infer causality, or can we circumvent this in any way using observational data available? One way to try to do this is to use something called an instrumental variable. And the ideal instrumental variable is associated with the predictor, but it's not associated with the outcome, except via the predictor. And so the hope is that if you can identify such a thing, that maybe then you can disconnect your predictor of interest from the confounding that may be important. So Jonathan Dukes, when he was a fellow, and I tried to do this using alcohol access laws as the instrumental variable, where the access laws themselves, the fact that someone lives in a place that either prohibits alcohol, as shown in the white counties here, or fully allows alcohol, as shown in the black, or kind of most useful, lives in a county that changed over time. So those are the crosshatched counties that switched. They all went from dry to wet in 5 years. And the hope is that that shouldn't be associated necessarily, especially in the same place over time, with those worrisome confounders. And in fact, we found, focusing on those counties that changed their alcohol access laws, that first of all, in validation analyses, that alcohol abuse did go up, alcoholic liver disease did go up, and interestingly, atrial fibrillation did go up, suggesting that perhaps there is indeed a causal relationship between alcohol and AFib. Now, Shalini Dixit, who you all know now because she's thankfully one of our cardiology fellows, when she was a medical student, published this very important paper that kind of asked the question, well, if someone's been drinking, is the cat out of the bag? Are they now destined for AFib, or can cessation of alcohol actually still reduce their risk? And indeed, that's what we found using the ERIC cohort, that those who stopped drinking experienced a lower risk of AFib. And Alex Voska-Boynik, who, as many of you know, is an Australian who was with us for some time as an EP fellow, published this extraordinarily important paper with Peter Kistler there in Australia, in Melbourne, Australia. And Alex has very kindly, generously mentioned that that paper by Shalini was a bit of an inspiration for him, and this was his PhD project that he was able to get published in the New England Journal, and I think that was well-deserved, where they took patients with atrial fibrillation and who drank pretty heavily, and randomly assigned them to avoid alcohol, or they were instructed to avoid alcohol, versus go ahead and continue drinking as you would. And they showed a really remarkably large magnitude of effect here, where those instructed to abstain experienced a lower burden of AFib. Now, this begs the question, how is this happening? How is alcohol doing this? So we do know that in some people who drink very heavily, they can develop a cardiomyopathy, and we think of that as affecting the ventricles. We also know separately that the atria are more prone to dilation and fibrosis than the ventricles, and this may be related to the fact that atrial fibroblasts are more reactive than ventricular fibroblasts. So maybe you don't need a whole lot of alcohol to cause some dilation of the thin profibrotic atrium, and there's some evidence for this now. There are a couple of studies that have shown what's shown here, which is that in the EP lab, that you will find lower left atrial voltage among people who drink more alcohol. And it's been well established that lower voltage is a very reliable surrogate of scar. We leveraged data from the Framingham Heart Study, So Dave McManus, who many of you, I'm sure, remember as a resident and a cardiology fellow with us, he's now at UMass and doing really large and important things there, first authored this. So we leveraged the Framingham Heart Study, where they have serial assessments of alcohol. They also have the benefit of having serial echocardiograms and then very rigorous ascertainment and adjudication of AFib. And what we found was that those who drank more experienced a greater enlargement of their left atria prior to their development of AFib. Admittedly, they're not all wearing continuous monitors, so it's possible that there's some effect cause there where the alcohol led to AFib, which led to left atrial enlargement. But it looked like, as best we could tell, that alcohol led to more left atrial enlargement, which then mediated some of the relationship between alcohol and AFib. Now, these are all, everything I've just talked about is really chronic effects. But our patients tell us that acutely, drinking alcohol seems to trigger their episodes. And this has been a real area of interest for us. And so we recently published this study that took several years, funded by an R01, where we enrolled paroxysmal atrial fibrillation patients who drank at least once a month, fit them with Zeo patches, and fit them with alcohol sensors, and found that indeed, drinking just one drink of alcohol essentially doubled the chance that a discrete AFib episode would happen in the next few hours. If they had more than 2 drinks, the risk of a discrete, particular, temporally related AFib episode just in the next few hours would occur more than, the risk was increased more than 3-fold. Separately, looking at the alcohol monitors, indeed, the higher the peak blood alcohol concentration or the area under the curve of the alcohol concentration was also associated with near-term atrial fibrillation. So this then begs the question, okay, so that was in these people that you know have paroxysmal AFib, presenting to this tertiary center. How important is this in the general population? And a major challenge is, you know, how often does alcohol actually lead to, in the short term, a first atrial fibrillation episode? And here again, this is a more recent study that has not yet been published. We try to utilize an instrumental variable. So I have this collaboration with a Bluetooth-enabled breathalyzer device that is successfully marketed to just people around the world. And this is an example that Kirsten Aschbacher first authored that we got published in Nature Digital Medicine, where she applied a machine learning algorithm to the blood alcohol concentration levels and essentially was able to predict and reproduce this in multiple validation cohorts when the blood alcohol concentration or what factors would make the blood alcohol concentration exceed the legal limit. So now, one of our great medical students, Sydney Ong, who did a year of research with me last year, he's now applying for medicine residencies, used the same data to identify recurrent nationally recognized events associated with the most common use of those breathalyzers and the highest blood alcohol concentration. The idea being that those events might then serve as an instrumental variable to tell us about near-term admissions for AFib that we gleaned from the OSHPA database over 11 years that captures all emergency department visits in California. And indeed, in summary, these various events that were empirically derived based on those breathalyzer measurements were associated with more atrial fibrillation episodes, highly statistically significant. We did look at SVT visits to emergency departments as a negative control and could not find a relationship, suggesting there's something unique about acute alcohol consumption and AFib. And then we looked at the people who hadn't had a diagnosis of AFib, didn't have AFib for at least a year in California, at least they didn't come to a hospital or ER visit or have a procedure for AFib, and found that those events, again, a surrogate, an instrumental variable reflective of excessive alcohol consumption, was associated with their first episode of AFib. Now, the ideal way, of course, to deal with this issue of confounding is to randomly assign the predictor. And the kind of magical thing about that is that it not only addresses measured confounding, but also unmeasured confounding and even confounders we don't even know about. The idea being that those will wash out with randomization. Now, this is a little difficult in atrial fibrillation, especially because such a trial can get expensive quite quickly and could take a long time. So we were interested in doing this and honing in on the mechanisms of, again, not the chronic effects, but the acute effects. What is alcohol doing to the electrophysiology? Is it doing anything to the electrical properties of the heart in the near term? And to describe this, this relies a little bit on this now fairly old model of atrial fibrillation or kind of concept of what atrial fibrillation is that was first described by Gordon Moe. It's called the Moe's multiple wavelet hypothesis. This is now a little controversial as people talk about rotors, and probably some focal automaticity may be important in some, but the general concept is still relevant, and that is that in order to initiate and maintain atrial fibrillation, you need a certain number of wavelets that to simultaneously coexist. And importantly, in order for that to happen, those wavelets need to be short. And in order for those wavelets to be short, you need the refractory period to be short and or the conduction velocity of those wavelets to be slow. So in general, and this is fairly well accepted, there's a sense and also animal data, computerized models, that the shorter the atrial effective refractory period and or the slower the conduction velocity, the greater the propensity for AFib to initiate and maintain. So this was a trial that we called Holiday, where we randomly assigned patients undergoing AFib ablations to receive an alcohol infusion versus a matched volume and osmolar concentration placebo. It was double-blinded. Patients were under anesthesia. We did apply an anesthesia protocol that we thought would minimize any EP effects. The operators didn't know what the patient received. The alcohol was titrated by serial breathalyzer measurements to hit and then maintain an alcohol concentration of 0.08%. And then the placebo groups, the coordinators would call out these kind of scripted numbers to try to maintain blinding. And we were adequately powered with 100 patients. And here is shown where the catheter positions were for all of these procedures. So D is the left upper pulmonary vein, C is the right upper pulmonary vein, A is the crista terminalis, B is the bundle of His, and E is the coronary sinus. And we assessed both before and after infusion in both the placebo and alcohol patients, the atrial refractory period. We could infer the conduction velocity by measuring the conduction time, pacing from one place and seeing how long it took to get to another place, and we could do that before and after. And then we tried to induce AFib in everyone in the hopes of comparing, again, alcohol to placebo. And the main findings are shown here. In fact, our primary outcome was the reduction in the refractory period in the atria. On the left here, each row represents a different patient. These are the alcohol folks. These are the placebo patients. Red means that the ERP went down. Blue means it went up. White means we weren't able to measure it for some reason. And hopefully you can see that on the left, the alcohol group, there is more red than in the placebo. And the way this is arranged, the pulmonary veins are here on the right. And you see the red seems to be more so, especially in the pulmonary veins. And indeed, the proportion where the ERPs went down was significantly greater in the alcohol group than the placebo. And when we looked at this in a continuous way, it was really the pulmonary vein ERPs that went down in the alcohol group, and they didn't at all in the placebo group. And outside the pulmonary veins, those areas didn't seem to be as affected by the alcohol. And this is very interesting, given our observations from the ablation experience, that the pulmonary veins, or the junction between the pulmonary veins and the atria, seems to be important. And it seems to be that way in alcohol. Now, we were not able to demonstrate a difference in AFib inducibility between the alcohol and placebo groups, and there are several potential explanations for that. One is that we may have had just kind of too heavy a hammer, where it's just too easy to get AFib going in these patients who already had AFib, and in fact, a very high proportion did exhibit AFib with our fairly aggressive attempts to get that going. Two, it's possible that general anesthesia somehow affected things and didn't allow us to see a difference. The other kind of interesting idea is that there's still something that's more delayed. This was very immediate. We got again, alcohol up to 0.08%. And in our study where we looked at the ambulatory population and looked at kind of free living people and the time it takes between alcohol consumption and the initiation of AFib, it looked like that tends to happen around 4 hours, maybe peaks at 4 to 6 hours. So whether that's related to some alcohol metabolite or it just takes that long for the probability to kind of build up and manifest as AFib, or whether it's some delayed autonomic change, perhaps related to vagal tone, we still don't fully understand. Okay, shifting gears from the good news of alcohol to the better news about caffeine, perhaps. So Shalini Dixit again, our superstar, published this important paper that I admit I wasn't super sanguine about at the time, at least when we initially submitted it. And this is one of these papers that got snatched up and was accepted by the journal, and I regretted not aiming a little higher initially. And this was picked up by the New York Times. And the reason I didn't think it was the most monumental thing, although Shalini, as always, did a really outstanding job, was because it was negative. We didn't find any relationship between alcohol consumption and cardiac ectopy. The other really important limitation was that this was among patients or participants in the community dwelling people in the cardiovascular health study. And we just looked at their PAC and PVC counts during Holter, while they were a 24-hour Holter, and compared that to what they generally said they consumed in terms of alcohol, in terms of coffee. So we didn't know how much coffee they were actually consuming while wearing the halter. We kind of inferred that. However, as one dives into the literature on this, you find that many studies that look at caffeine as a predictor of arrhythmias tend to be either negative or even demonstrate there might be a protective effect. So this meta-analysis was very close to doing that, looking specifically at atrial fibrillation. And if you think about it, there are several reasons that caffeinated products could actually protect against atrial fibrillation. So number one, coffee and tea have been shown in multiple studies to have anti-inflammatory effects. We know that inflammation is sufficient in animal models to induce AFib. We and others have published that individuals in community dwelling cohorts that have higher levels of CRP or IL-6 have higher risks of AFib. Caffeine, of course, is antivagal, and it's becoming more clear that at least in many patients, higher vagal tone seems to be important in contributing to their AFib. And then also, interestingly, contrary to what everything I just said about the refractory period in alcohol, there's some evidence that caffeine may prolong left atrial refractory periods. So this is largely what motivated this paper that E.J. Kim, who just finished her EP fellowship with us, first authored, where we did we performed the largest analysis to examine this question using the UK Biobank, almost 400,000 individuals. And we looked at all arrhythmias, thinking that there should be a high risk for some arrhythmias related to coffee. And interestingly, we found this very consistent relationship, and this demonstrates the stepwise nature of that relationship, where the more coffee that individuals reported consuming at baseline, the lower the risk of all their arrhythmias. And when we looked at each individual arrhythmia, this held true for AFib and, interestingly, SVT. It didn't for some of the others, such as PACs, PVCs, but it didn't show a harmful effect there. And the numbers were probably or perhaps too small to detect a significant relationship. Now, That, of course, relies on self-report of coffee consumption, and that's prone to the same confounding that I've been describing, and is clearly an observational study. So here we also employed another type of instrumental variable, and that is a common genetic variant, or SNP, that is associated with the predictor and at least ostensibly not associated with the outcome. And that's the idea of this Mendelian randomization, where we leverage the fact that in meiosis, or the thought or belief that in meiosis, whether a given person receives one allele or another is fairly random, at least, again, as far as we know. And if you can find a genetic variant that is associated with your predictor, you can do this Mendelian randomization. And oftentimes, what are used are SNPs associated with metabolism of the substance of interest. This is commonly done in alcohol research, and it's been very well established that those that metabolize alcohol more quickly, as determined by their genetic variants, tend to drink more. And in fact, having fast metabolizing, alcohol metabolizing SNPs is a risk factor for alcoholism. So we demonstrated in this cohort that those who, per their genetic variants using a polygenic score, were expected to metabolize caffeine more quickly, they really did consume more coffee in the UK Biobank. And here we could find no significant relationships, and it wasn't even really close. Importantly, this did not show a protective or didn't suggest a protective relationship between at least caffeine and AFib, but there was no evidence of a harmful effect. There was no evidence that those expected to consume more caffeine based on that Mendelian randomization would experience a heightened risk of arrhythmias. Okay, so again, ideally, we do a randomized study. And this is where cardiac ectopy in particular becomes useful, because we all have cardiac ectopy. We all have a PAC count or PVC count. It's extremely rare for people to have zero, especially if you monitor them long enough. And one of the things we've come to realize is that cardiac ectopy may be more clinically relevant than we previously thought. So this was a fantastic study that Tommy Dooland really not only first authored, but substantially elevated by contributing multiple novel ideas, where we showed that PAC count not only predicts AFib, but also that it seems to be probably the single most potent predictor of AFib. So in this case, we compared it to the very complex Framingham model and showed it was all by itself, just a PAC count in community dwelling people was just as good as the Framingham model. And in fact, if you added it to the Framingham model, it improved it. Jonathan Dukes published this study, so we know from the EP lab now that heart failure patients with very frequent PVCs, those with systolic dysfunction in particular, if we can eradicate their PVCs, often with ablation, we can improve and sometimes even normalize their EF. So we asked the question, well, does a PVC count predict heart failure in the general population, in the general community? And we found that yes, indeed it does. And these were not high burden PVC patients. Again, these were community dwelling people, both suggesting that this regular old ectopy, the frequency of it may be important. So this is what motivated Crave, coffee and real-time atrial and ventricular ectopy that I suspect many listening in were kind enough to participate in. Thank you for that. It was a very fun study to conduct. So we enrolled 100 volunteers, fit them with Zeo patches for 2 weeks, a continuous glucose monitor, a Fitbit to record both step counts as well as sleep, and then obtain saliva to genotype DNA for caffeine metabolism. We also used this feature that we now offer for all of our studies that we call geofencing using our Eureka mobile app. So this was first authored by Kaylin Nguyen. When she was a medical student, as many of you know, she was also a resident at UCSF. She's now a cardiology fellow at Stanford, and demonstrated this proof of concept that we could geofence passively hospitalizations, essentially. But in this case, we geofenced for coffee shops. We also reimbursed for all coffee consumed as long as the participant provided a date stamped receipt as a way to validate their report of actual coffee consumption. So I would love to give you some of the results. Frankly, we're still working on them. This has been accepted for a late breaker at AHA, so I have to embargo those at least until then and for a few more weeks. So in terms of this idea of things being patient-centered, the question is, well, what kind of study would arrhythmia patients, in this case, AFib patients, like to do? And this led to this meeting of patients and investigators where we asked patients with atrial fibrillation, what is the most important thing to you? What are we missing as investigators? And what would you like us to focus on? And they told us, we want to know about triggers. And as everyone who takes care of AFib patients knows, there is understandably a great interest in why did I develop AFib just now? Was it this? Was it that? Was it the cantaloupe I just ate? Was it that exercise I just did? And they're very interested in trying to figure that out. And that motivated this study that we were fortunate to get funded by PCORI. And the first step was to first characterize, well, what do patients think are their important triggers? And this was published by Chris Groh as a fellow with us, who's now at the University of Utah. And this is what they told us: alcohol being the most common, caffeine they thought the second, and exercise the third. And so we designed this study using the Eureka app, where we randomized patients around the country to either just track their AFib or to undergo their own randomized N of 1 tests to test their triggers of interest. We gave everyone an AliveCor cardiomobile. And then for those that underwent their own N of 1 test, we gave them their results in what we hope was an easily digestible way, as well as the probability that their trigger really was their trigger. And the idea, or the question is, if people are armed with that information, can that actually improve their quality of life and reduce their risk for AFib? So I'm in the process of also analyzing these data, and was very fortunate to get this also accepted as a late breaker at AHA. So look forward to sharing those results also in a few weeks. Okay, just in the last 5 or so minutes, I'm gonna shift gears, as mentioned, to talk a little bit about procedural approaches, which obviously are of great interest to our patients. And to remind you all of this important paper that Ziggy also first authored when he was a fellow, where we asked the question whether left ventricular catheter ablation leads to ventricular emboli. There had been many reports looking at AFib ablation, but the relationship between AFib and stroke, AFib and emboli was well established, and we assumed that this was happening related to cardioversions, low flow in the left atrium, a lot of burns in the left atrium. And so we were very surprised that such a high proportion of our patients undergoing left ventricular ablation procedures experienced a new brain embolus. So it's about 60%. And this kind of shook a lot of people who do a lot of these procedures and made us wonder, how can we reduce that risk? And we could find really no clear predictor. So it didn't matter what their ACTs were, how many burns, where the burns were. And given some other evidence that simply manipulation in the aorta may be dislodging debris that leads to emboli, and also recognizing that the transeptal puncture has become so common in the EP labs, and the tools to do so have made maneuvering the catheter so much easier. Now with these deflectable catheters in particular, we thought it made sense to do a randomized trial that we were able to get funded by PCORI, in this case a multi-center trial that we've called TRAVERSE, which stands for Transeptal versus Retrograde Aortic Ventricular Entry to Reduce Systemic Emboli, where we're testing the hypothesis that a transeptal approach to left ventricular ablation would result in a reduction in the cerebral emboli compared to the more conventional retrograde aortic approach. And then second, we still don't really understand what these emboli are doing, if they're even causing any issues. We know that if you re-image patients' brains a month later, they're often gone. So we also are looking at whether a transeptal approach may mitigate neurocognitive decline after these procedures. So these are the current sites. We are actually in the process of adding about 4 more. The goal is to enroll 150 patients. It's somewhat arduous. Each and every patient, as our fellows and faculty and certainly clinical research coordinators recognize, can take quite a bit of work. We have about 64, 65 patients enrolled so far, the great majority from UCSF, thanks to all of our EP fellows and faculty and our outstanding clinical research coordinators. And so I really want to highlight them. They are just terrific, Kathleen Chang, Gracie Wall, and Michelle Yang. I also wanted to share their pictures because many of you on the wards may encounter them as they do their jobs consenting patients. They're very busy doing really fantastic work, enrolling many patients for many studies, but they are well deserving of a shout out here to in my as a token of my appreciation for their great work. And I should mention that in addition to enrolling at UCSF, they're also training all the coordinators at all the other sites, and they're constantly pinging them and nagging them as I nag the PIs to get them to enroll. And they've been doing a really great job at that. I also wanted to share info about this study because many of your patients may be enrolled. We're looking for any adult undergoing an endocardial, as opposed to epicardial, a VT or PVC ablation. And the main inclusion is that the operator just has to feel like they can get there, either through a transeptal or retrograde aortic approach. This applies to many ischemic VTs that tend to be from the apex or the inferior wall, and PVCs coming from, for example, pap muscles or fascicular PVCs or VT. And then finally, just wanted to mention this study that was recently funded by an R01, also in line with this idea of trying to understand procedures that our patients are undergoing. So the NCDR has this AFib ablation registry, and the sites that are ever growing are shown in the map here. And the issue is that we know that the great majority of publications on AFib ablation, which is now the most common procedure we do in the EP lab and becoming extremely common around the world, those publications arise, not surprisingly, from randomized trials and or high volume centers where probably the most expert and by definition, most experienced operators are working. And so that's what we're learning about. The idea of the NCDR is that it will capture what's going on in the real world in these smaller centers, other centers that aren't represented in the majority of publications, even though many of these centers all taken together are probably doing the majority of the actual procedures. So that's good. However, the registry as it currently exists only collects data regarding the procedure on that day and during that hospital stay. And we know that a lot of the complications that occur once they go home. And the most dreaded complication, for example, atrioesophageal fistula, doesn't manifest for 3 weeks. And then, of course, they have no idea about effectiveness, which takes months or years to fully study. So in this R01, we proposed co-enrolling these NCDR participants into a Eureka-based study that we've called Vibrant, or Vibrant AFib, which stands for Volunteers to Investigate Best Results for Ablation and Novel Therapies for Atrial Fibrillation, where they will enroll, connect up their medical records separately. We have funding to provide 1,000 alive cores. We will also employ the same integrations with HealthKit, so anyone with Apple Watches will be getting those data. We'll ask about interim lifestyle. There's a big question after you've had an AFib ablation. Now, can you drink alcohol? We still don't really know. We can look at coffee consumption, predictors of effectiveness and outcomes, and maybe use of Apple Watches, circling back to the beginning. And again, this is going to be more data than I certainly can, and even my current mentees can fully manage. So I invite you all to think about areas for collaboration there as well. So in conclusion, bouncing back to the beginning, self-monitoring or diagnosis for arrhythmias among patients or directly to patients is already here. and we require ongoing rigorous study to guide optimization of those technologies. Just because it's here doesn't mean we fully understand how to best use those technologies. Physical activity, as usual, is a good thing. Alcohol increases the risk for AFib. I can say that quite confidently now, both chronically and acutely. Caffeine, where there's still a lot of room for study, does not appear to be an important risk factor for arrhythmia. So incidentally, it probably does not make sense to broadly preclude or admonish our arrhythmia patients to avoid coffee for that reason. And there are many research opportunities to improve the safety and effectiveness of our established procedures. And of course, all of this is done in collaboration with many, many people. And so I want to thank all of them. And it's always a joy in particular to work with research mentees that are often the inspiration for many of these ideas and always help to make their realization better. So I can stop there and see if there are any questions.
Thank you, Dr. Marcus. I do see one question right here saying, although caffeine does not appear to be an important risk factor for arrhythmia, is there any research into whether caffeine increases palpitations?
A very good question. I don't know. So yeah, that's one possibility, that if maybe it's not, for example, triggering atrial fibrillation, but making one more aware of their atrial fibrillation via the catecholamine-like effects. My sense is there's quite a bit of heterogeneity, and that even the type of arrhythmia probably matters. I had a patient, just as a anecdote, who had this a jaw issue that resulted in chronic pain that could not be fixed in any other way. And so he was on fairly high dose opiates, and he actually took caffeine pills. And he knew, and it was pretty clearly documented in his particular case, if he exceeded a certain amount of caffeine, his PVC burden went up. So it's a question of, the fact that in the general population, in most people, that caffeine consumption doesn't seem to heighten the risk does not, of course, preclude the possibility that there are some individuals in whom it does. We still don't even understand why some people feel their PVCs and other people don't, irrespective of caffeine. So there's a lot of work to be done related to symptoms, and that's a great example of that, is understanding the perceptions of what's going on in the chest and with arrhythmias.
And then a follow-up question for that was, do you recommend or do you counsel your patients to stop their caffeine intake if they're having palpitations without documented significant arrhythmias?
Yeah, so what I do now is, so first of all, if someone's not a coffee drinker, I certainly don't recommend they start. So I think this is relevant to those who otherwise would prefer to drink coffee or enjoy coffee, and where it would enhance their quality of life. So I actually recommend that they experiment, which I think is fine, as the great majority of these arrhythmias are not imminently dangerous. And most of the time, it's not going to make anything worse. I, of course, always counsel moderation, but I recognize it's possible that some individuals may actually have their arrhythmia triggered by it. So I suggest give it a try. I have, again, completely anecdotally, had some patients with atrial fibrillation that are so delighted to get this news, and they try it. And I've had some patients where it seems like, could be true, unrelated, their AFib actually goes down. Chris Wong, who's now an EP fellow, and I are now in the process of working on a randomized trial to examine abstinence versus ongoing coffee consumption after cardioversion to try to really test that a little bit more rigorously.
Great. I have Dr. Kaiser has a question, so I'm going to allow him to talk, and I think we should be able to hear him. Hi, Dr. Kaiser.
Hey, Jorge.
Oh, great. So congratulations on a very exciting body of work, Greg. I have a couple of questions. First, for the TRAVERSE study, I'm curious to what extent you were able to link atherosclerotic plaque in the aortic arch with these embolic lesions. And then I'll ask you a second unrelated question.
Yeah, unfortunately, we weren't, because we didn't do any sort of rigorous evaluation of their aortas, because these were PVC VT patients. We didn't have TEEs on all of them. That was a big question when we designed the study and among some sites. Should we get a TEE on everyone? But that's just not what's done in clinical practice. I will say, so what we did to try to placate reviewers there as kind of a surrogate, we looked, they all had, at least all the retrograde aortic ones, all had femoral arteriograms, and we shared all those, and those were all quite pristine. And I will also mention that many of these individuals, I think there's a common perception that these were kind of older vasculopaths, but many of these patients, including those with the emboli, were young, healthy, just PVC patients. And I know that some of the Traverse patients that have already manifested emboli were the same. I'm talking about people in their 30s who are completely healthy and just have a PVC. So almost certainly having atherosclerotic plaque, or one would think that would increase the risk. But I think on the flip side, even being, as far as we can tell, quite healthy from that perspective may not be enough to protect patients from that outcome.
Thanks. And the other question that I had is regarding increased vagal tone, increasing risk of atrial fibrillation, which you mentioned as a potential mechanism for caffeine. I'm just curious how you bring together the fact that if you have low vagal tone and you have greater heart rate variability, that's associated with all kinds of adverse outcomes. Can you kind of bring those two together a little bit for us?
Yeah, it's tough and complicated. And, AFib is kind of backwards in multiple ways to a lot of the other cardiovascular risk. And alcohol may be an example of that, right? Where moderate alcohol consumption seems to reduce the risk for MI, at least again in observational studies. And Ken Mukamal and I hopefully can prove that in a randomized trial. We also know, for example, that highly trained athletes can develop AFib. And that's another big question about, well, you're going to recommend, you're saying physical activity is good to reduce AFib, but what about these triathletes? And I often, again, this is fairly anecdotal, but see this in high endurance cyclists have this high risk for AFib. And we don't know whether that's a left atrial enlargement, remodeling thing, or whether it's a vagal thing. I don't think it's as simple as those with more vagal tone have a high risk for AFib. It's more, there's some relationship there, and whether it's related to the ganglia that are right there in the atrium, or, as I suspect, there's some underlying propensity to AFib, whether it's having a shorter atrial refractory period, something structural in their pulmonary veins, plus then the vagal tone on top of that. So that's all a lot of hand-wavy way to say, yep, you're absolutely right. It's contrary to what we usually think, because we do usually think that more vagal tone is healthy. But again, I don't think the vagal tone, I think it may be necessary in some individuals, but it's almost certainly not sufficient. There are other things going on there.
Thanks for that.
Well, thank you, Dr. Marcus. I think there were a couple more questions, but I know that we're out of time, so I just want to be respectful of everyone on the call. Thank you, everyone, for joining us. This lecture will be available on our YouTube page, so feel free to review it, and we'll see you next week.
Thank you.